This is the video of a giant cavernous sinus hemangioma, 52-year-old female patient with 6-nerve palsy, as well as partial third, trigeminal numbness, mild hemiparesis. This very large hypervascular mass compressing the cerebral peduncle, temporal lobe arising from the cavernous sinus. Imaging is compiled with a very large cavernous sinus hemangioma. We can see the displacement of the neurovascular structures and the involvement of the petroclival region. The rationale for the procedure is clear: improve preoperative symptoms, reduce mass effect on the brainstem, and prevent new neurological deficits. Patient will be positioned supine with Mayfield head pins, head rotated towards the opposite side. Of course, we'll use the surgical microscope, navigation system, high-speed drill, bipolar, Doppler to map the carotid artery, and neuromonitoring for cranial nerves. The key steps include the interfacial differential flap for the temporalis muscle so we can protect the frontalis branch of the facial nerve. We'll perform a 2-piece orbitozygomatic craniotomy. Then we'll do a middle fossa dissection extradurally with an anterior clinoidectomy. We'll perform extensive extradural dissection of the tumor with a small component of intradural dissection given its very large size to finally perform an en bloc removal of the tumor mass. The alternatives to a surgical procedure are first observation, which is not indicated given the large dimension of the tumor mass and the current symptoms, and similarly, radiotherapy, also not indicated given the symptomatology present and the large size of the tumor. The main risks of the operation include worsening of current symptoms with multiple cranial nerve injury and the risk of injuring the carotid artery or any of the perforating branches, and also risk of significant high blood loss because of the very vascular nature of this tumor mass. The potential benefits include the improvement of preoperative symptoms, the prevention of new neurological symptoms, and importantly, the complete removal of this mass will be curative. A few words on disease background. Cavernous sinus hemangiomas are very rare intracranial vascular malformations. They are purely intracavernous sinus lesions, but can extend beyond the cavernous sinus towards the supraorbital fissure, the sella, meticulous cave, or even the petroclival region. The cavernous sinus hemangiomas are more common in female, especially in the 5th decade of life, and presents, as we see here, with headaches and multiple oculomotor nerve pulses. On the MRI, it's very important to differentiate them from other tumors, like, for example, chondrosarcomas, as they are also T2 hyperintense. However, they might show intravascular signal, although these are silent for the most part on angiography. And finally, the treatment will include, when they are small and asymptomatic, simply observation. When they are symptomatic, but mildly symptomatic, perhaps radiation is an option. But when they are large, like in this case, radiosurgery is not indicated, and a surgical operation is the only way to alleviate symptoms. Here are a few anatomical dissections to show the step-by-step approach, the extended middle fossa approach. And now we have performed our orbitozygomatic craniotomy in 2 pieces. We're peeling the middle fossa dura to start exposing the lateral aspect of the hemangioma. We are expanding our foramen ovale with V3, and now we're going to find also the middle meningeal artery. We dissect posteriorly to find the greater petrosal superficial nerve. We're now dissecting the dura of the temporal lobe away from the superior and posterior aspects of the hemangioma. We've gone all the way to the petrous apex, and we keep dissecting the dura on the top, and now posteriorly. We want to release the hemangioma capsule as much as possible. We stimulate for 7th cranial nerve at the level of the ESPN. Now we start opening the capsule of the hemangioma. Of course, it bleeds as expected. This confirms our diagnosis and suspicious diagnosis. And then we start dissecting first the branches of the trigeminal nerve, we think, V1 and V2, displaced inferiorly. We can isolate them from the tumor mass to the capsule of the hemangioma. We find the carotid artery in the cavernous sinus. As you see, we'll continue shrink the capsule of the tumor with bipolar coagulation. We are releasing the dura now at the level of the petrous apex. Now we are again anteriorly, and we found the carotid artery in the cavernous sinus. We coagulated the intralateral trunk that is providing direct vascular supply to the tumor. And now I'm finally opening the dura at the base of the temporal lobe, so I could access the highest point of the tumor. This is the portion that is partially intradurally done. I can see the optic apparatus. I also map my carotid artery along the cavernous sinus, and I'm dissecting the tumor now of the medial wall of the cavernous sinus. We can see the prominence of the cruritocranial ligament. We can see the third nerve intradurally as it goes into the cavernous sinus roof. And that's again a nice view of the cruritocranial ligament. And finally, we dissect the tumor completely off the cavernous sinus carotid. Now we're drilling the petrous apex and petrosal process of the sphenoid bone, because the tumor is going into the petroclival fissure, extending to the venous channels along this fissure. So we need to remove it out of this area, for which we drill extensively, so we can finally transect the dura and the tumor along with it. This is the area where the abducer's nerve will be found. Remember, this patient had a complete 6-nerve palsy for compression at this area, we believe, so we aim to preserve the nerve. We are able to finally completely remove the tumor in an extradural mostly fashion. That's the location of the 6th nerve, basilar artery, the peduncle, dura the petroclival region. And this is the post-operative imaging of the patient, showing a complete tumor resection. Patient had significant improvement of the retroorbital pain, also normalization of the hemiparesis and of the 3rd nerve palsy. However, persistent 6th nerve palsy and some degree of trigeminal numbness.